Welcome to the introduction to simulation in healthcare. Setting the scene. In this element, I would like to discuss how we can prepare participants and also facilitators to actually run simulations that are goal-oriented. My name is Peter Diekmann. I'm work and organizational psychologist, and I'm a professor with the University in Stavanger, looking at patient safety and healthcare education. The honor to work together with a great team. I'm presenting our thoughts here together. Thank you, dear colleagues, for your contribution as well. Simulation in healthcare comes in many different forms with many different goals in many different settings. So we have mannequin-based simulations, for example, that are very nice and practical to train how people can actually optimize the interplay between human technology and organization. We have part task trainers that allow for the clinicians, for example, to practice certain skills that they need, psychomotoric skills. When you intubate a patient, for example, when you place an IV line. We have role play situations where we can really look at how can we optimize the communication between the healthcare professionals and patients, but also between healthcare professionals within the team, for example. We have virtual environment simulation systems that, for example, would also allow to look into different layouts of rooms, to interact also with different people in a very standardized way, for example, where we have quite interesting possibilities with this. The common ground, I think, with all these different settings is that people are coming together. Simulation is a social practice. And in one form or the other, people do as if they would intubate a patient when they actually intubate a mannequin. For example, they do as if they would interact around a real patient where they are interacting around the mannequin-based simulator, for example. This has huge potentials, but how we can actually harvest these potentials is a matter of what we do with the equipment that we have, how we use our simulations, and I would like to explore that a little bit more. It's actually a thought that is not so new. The airline industry here already discovered that in 1973. The key is the program, not the hardware. So you can have very nice simulation scenarios, you can have very nice simulation equipment, but that does not necessarily mean that you already have a good simulation-based training as well. There's more elements that you would need for this. Participants, a good course concept, for example. You need enough time to put the course concept into practice, for example. So when we talk about simulation-based training, the equipment is the one side, but how we actually are using it is the other side that would decide on how much of the learning potential simulation has can actually be harvested. Often people ask, does simulation work? And there's many studies out there that show, yes, simulation can work to increase the satisfaction of participants. They like to participate in it. You find studies that can show that people learned something in the simulation on a knowledge level, on a skills level, on an attitudes level. You can also relate actual changes in the workplace to simulation, and you can show that the changes in the workplace that happened due to simulation actually also had positive effects on patients, on the economical side of care, on the well-being of staff. For all of this, we have studies. So the question is probably not anymore, does it work or not? Yes, it does work. The question is, how does it work? Under which conditions? With whom? For what? So basically, what else do we need besides to have a nice simulation scenario and simulation equipment to have simulation training that is effective and in reaching its goals? One of the elements is to set the scene for this. What are in principle aims and objectives of simulation in healthcare? The main objective probably is still that we help participants to treat patients well, safely, efficiently. We can, for example, set up situations that are seldom, that are quite critical, that you really get it right, that are dangerous potentially for patients. And we can create simulations that would allow participants to gain experiences with this. A little bit like a vaccination concept. You have experienced the challenge in the simulation setting, and then the hope is, and also the data shows, that you would be better prepared for in the clinical practice to actually deal with the challenge. So the first line discusses the overall educational use of simulation. That can be across the whole lifespan of a professional, from pre-graduate education of medical students, nursing students, ambulance students, whatever professions people have. Simulation is also then used quite a bit in the transition phase, end of study, beginning to work as a professional within the specialist education, for example, for nurses and for doctors, but also throughout the whole career with continuous professional development. There's also examples for that where simulation is used. So simulation can be used in one form or the other to teach somebody to create learning opportunities. In recent years, we discover more and more different uses of simulation. The next one is to optimize work system designs, where we can actually set up simulations to try to find out how should we build the wards, how should we build hospitals. So also new forms of simulation. If we did not mention so far board simulation, where the idea is, for example, you take the drawing of a ward and you move little figurines across the ward to try to see, what would be ways that the people working in this ward have to negotiate during their work. How often would they need to go back and forth to have fetch equipment, for example? Is there a smarter way to build the wards so that people have the optimum amount of going back and forth? We also don't want to design that completely out of the system, because that's also a chance to take a little breathing break when you're in a very busy work shift. So we can use simulation to not teach people how to work in a ward, but to optimize the ward layout itself, for example. And the third aim also I would like to at least mention shortly is to perform research in simulation. So there's different forms of research. We can do research on simulation, where simulation becomes the research objects. How do we build good scenarios? How do we run effective debriefings, for example? We can also use simulation as the research setting to investigate different elements. For example, leadership behavior. There are studies that looked at leaders in different stages of their career and how they would behave in a certain complicated simulation situation, where the nice benefit of using simulation is that you have situations that you can control very much, but still also that are pretty close to the clinical environment. Within this presentation here, we would like to mainly concentrate on the educational use of simulation. We just wanted to mention the other parts as well. When we take this educational use of simulation, one way of looking at this would be to distinguish knowledge, skills, and attitudes, and then to see different basic types of situations. As I mentioned before, we can look at care situations. The first line, you handle seldom critical, sensitive, costly situations. The seldom complications that might occur in the treatment of a patient. The situation where you really need to activate all your team members quickly. How do you coordinate all the expertise that is in the room in the best interest of the patient, for example? All this would be a way of teaching, of creating learning opportunities for healthcare professionals and students. Another angle, basically also on the same thing, would be to help people understand how do you actually perform well under variable conditions of everyday work. A lot of times when you think about education, when you think about safety, there's the notion of let's standardize things. If everybody is working according to the standards, everything will be fine. But healthcare, patients, human beings are variable. We never are the same 2 times in a row. So there's always variability. And more modern ways of thinking about safety would be that we help people not only to function under standardized conditions, but to help them to actually function also in a effective, safe, cost-effective manner under these variable conditions. And we can use simulation to actually help people understand how do you do that. We can also use simulation to help healthcare professionals to stay healthy. It's a burdensome work that people are doing, and how can we set up scenarios and debriefings where we set the focus on how do you keep your own mental, physical health while you're helping others. That is maybe also due to COVID, a perspective that has been there all the time, but I think where people are also more receptive now to address this. Also to look into the economical aspects and also sustainable aspects of healthcare would also be, for example, a very interesting way of looking into the use of simulation. On all of these different topics on the left here, we could work on the different levels in knowledge, skills, and attitude. That's a question of scenario design. That's a question of good learning goals, for example. You can run simulations in simulation-based centers. You see an example here where we have a simulator, we have dedicated rooms, and we bring the participants into the environment of the simulation center. That reduces interruptions from the work setting, so the beeper might not work in your simulation center. You can optimize the environment for teaching. You could, for example, prepare machines that they are switched off by remote control, and then you can have a situation that people need to solve with this technical failure, and that you can debrief afterwards. What impact does that have for treatment? How can you manage things like this? And also quite nice to have like a mental change of perspective. So you leave your workplace, maybe you drive to a different building, get a different type of coffee, and you're actually entering a different setting from your work setting that helps many people to actually get like into a learning mood, for example. The other idea is to take the simulator and bring it to the clinical environment. And you see a picture, same picture here. So could also be the actual room. They are so close to each other that sometimes it's actually not easy to see. Is that a real place or a simulation center? That's what we wanted to demonstrate with 2 times the same picture. So the idea is you take the simulator, bring it close to the work environment where people are working. You get actually the stakeholders together. So imagine you're running trauma team trainings in the actual trauma bay. Then you have real people working in this. If they find out in the debriefing, for example, hey, there's something that we need to optimize, you have the change agent already present. So that can be quite interesting, or at least a subset of the change agents. They often would need to discuss with department leadership and so on, but you have the clinicians there, and if they make an agreement, that can be quite effective to initiate the change, for example. You can really also look into the actual interplay of human technology and organization. It's not the equipment in the simulation center, but the actual work equipment that they work with. What's important to also be aware of risks. So, for example, in many simulations, you would use outdated medications because it's cheaper to use them, but also still quite realistic. But you should not leave those in the environment in which you have simulated. So it's very important to also establish safety protocols, that you take all the stuff with you that should not be left, for example, in the clinical environment. And scheduling can be quite hard. If the OR is needed for a real patient, well, then you have to not even start your simulation session, or maybe also cut it short, for example. So simulations can also run in different settings. What's important to note that simulation is like the social practice, as I said before, and each course has different phases. We have drawn a model here where the ellipse represents a simulation-based course. And then in the setting introduction, for example, you explain to the participants what is simulation-based learning about. You look into psychological safety, trying to create an atmosphere for the learning. In the simulator briefing, you explain to the participants how would you interact with the mannequin, with the part task trainer, with the role player, whatever your simulation modality is. And you help them to understand how can you actually work in this environment. Then you might have a theory input, like I'm doing right now. Breaks are important, not only for networking, but also to let new thoughts sink in a little bit. Then the actual simulation scenario. The briefing to the scenario, where you explain the scenario to the participants, where the next concrete course is about a certain patient, where you explain this patient to the participants. Then you run the scenario, you run the debriefing, and we will go into more detail with the debriefing later. But in the debriefing, you basically reflect on strengths and weaknesses in regards to the learning goal. And then in the ending, you discuss with participants, what can you learn? What did you learn from the environment here? What can you take with you? The arrow on the left is what we call the pre-briefing. Before people actually come to your simulation setting, they already get some ideas about what simulation is about. And then the arrow to my right, leaving the course, where it's actually about applying what you learned in your course in the clinical environment. The arrows within the ellipse, they represent that phases are connected. So if you, for example, don't manage to create a learning atmosphere in the setting introduction, participants might not be very open in the debriefing to discuss with you. If they don't understand how to use the simulator, you might spend half of your debriefing time trying to explain to them later why they had problems in the scenario. So the briefing part is quite important in this. Simulation also works because it's this nice combination between having experience episodes, but also reflective episodes. And when you look into the learning theories, one of the pretty old, meanwhile, models is by Kurt Lewin. The idea is if you want to help people work with a change, we need to unfreeze them. We need to bring them into a situation where they recognize, oh, that is not as I expected. My skills are not enough here. I need to change something. If I don't have that feeling, I will not change, because if I do things all right, why would I change? So we can create situations where we unfreeze people. Then we come with ideas of making a change, and then we help them to refreeze, or maybe not refreezing, but to reestablish new routines. So if, for example, in a simulation scenario, they recognize that they missed to talk about an important information around the patient, that is when we unfreeze them. We can then introduce systematic communication models like eSPAR, for example, or a systematic approach to the patient, the ABCDE approach. And then we can help them to actually train this idea in several scenarios, providing feedback in between. That is why simulation can be so powerful, because it can combine very relevant experiences also with these reflective parts. We still want to connect a simulation, the clinical setting, or the actual work setting, and the simulation setting. We want to connect them. One way of doing this is to minimize X in this equation, to bring the simulation reality closer to the clinical reality, buying an even better simulator, designing the scenarios more realistic, taking the simulator to the actual work environment. All this is good strategies, which would help basically to make the gap between simulation and the clinical reality smaller. We think what we should also consider is Y elements. And Y elements is all those elements that you can do only in simulation because it's unrealistic. I can treat 3 times in an afternoon a patient that has an anaphylactic shock is hopefully unrealistic, but very easy to do in a simulator, for example. To adjust the development of the patient in terms of the vital signs can help the learners quite a bit, can be a very effective teaching method, but is unrealistic again. In our use of simulation, we think it's important that we are becoming better in using the X and the Y elements to optimize the learning conditions. In order to make that work, we need to build on what Umberto Eco called the fiction contract. So if our participants don't want to simulate with us, if they challenge every little detail of our scenarios, if they don't engage into this fiction contract, if they don't want to believe us, then all is lost. Basically, we can design very good scenarios. If they don't want to engage with us, the learning outcome will not be so high. That is why it's so important that facilitators are actually able to create the learning atmosphere for simulation, to build the trust that participants actually want to work with them. So in conclusion, simulation offers many possibilities in many settings, but to harvest those, it's important to consider those different elements in the simulation setting and the connected aspects around this. Setting the scene, creating relevant scenarios, reflecting on them in the debriefing. And we will provide an example in the next video. Thank you.